Welcome to our webinar this afternoon to learn how to be successful with PQRS and programs associated, such as the value modifier. I'm Judy Burleson, the Senior Advisor for Quality Metrics at ACR. Let's get started. Let's look back a little bit to see how well radiology has been doing in the PQRS program. As you can see from this chart, the participation has steadily increased over the last 4 years to the point where radiology is one of the highest participating specialties in the program. You can see that in 2013, diagnostic radiologists have participated at a 64% level, and this is one of the top 10 specialties reporting in the program. Looking at incentives earned in 2013, radiology is also successful in that over 72% of radiologists that did participate achieved an incentive in 2013, one of the top 10 specialties. And looking at how radiology did in terms of payment adjustment, which is being assessed in 2015 based on 2013, as you can see, about 20% of diagnostic radiologists are receiving a penalty in 2015, compared to many other specialties where a much greater percent of individuals are receiving penalties. And looking towards the future, what the Secretary of Health and Human Services has stated, that the goals are to have at least 85% of all Medicare fee-for-service payments tied to quality or value by 2016 and 90% by 2018. And 30% of those payments being tied to quality or value through alternative payment models such as accountable care organizations by the end of 2016 and 50% of those payments by the end of 2018. Looking at the potential payment adjustments that physicians face in the next few years through about 2018 or 19, just not going to go through this completely, but in looking at where we are this year in 2015, that there is a potential penalty for reporting PQRS in 2013 of a negative 1.5%, that there is a negative 1% value-based payment modifier for groups of 100 in 2015 based on 2013, and a penalty of negative 1% from meaningful use, although radiology groups are able to use a hardship exemption for meaningful use for 5 years, to total a possible payment cut in 2015 of negative 3.5 to negative 4.5%. Looking forward to 2017, which is based on reporting this year, 2015, there's a potential for a negative 2% PQRS penalty, a potential negative 4% under the value modifier program, potential negative 3% under meaningful use, which would total a potential payment cut of negative 9% in 2017. Not a happy thought. Looking quickly at PQRS program eligibility, physicians and other clinicians who bill Medicare Part B and use individual MPIs are eligible for the program. This now includes EPs at IDTFs, independent diagnostic testing facilities, when billing professional component. However, the details of IDTF reporting is still pending CMS additional information. Also, individuals at critical access hospitals using billing method 2 are now eligible for the program. And a reminder that success in the program is evaluated at a tax ID and NPI level. So if a group uses multiple 10s, then they must meet requirements for each 10 NPI combination. Looking at changes to PQRS in the last 2 years, I'm going back to 2014 because there were substantial changes that CMS implemented in 2014. primarily the increased reporting requirements of 9 measures and across 3 national quality strategy domains. The emphasis is on the national quality strategy domains now. As you can see, the 6 domains here at the bottom of this screen. That is because of the PQRS association with the value modifier program, which I will go into later. Also in 2014, CMS implemented the new Qualified Clinical Data Registry option, which we will discuss a little bit later. And looking at changes in 2015, there is no longer an incentive for reporting. CMS is moving away from claims reporting, although I say that they're moving away. Basically, CMS will continue to allow claims reporting for the next few years at least, but there are no new measures, and CMS is dropping measures that were reportable only through claims reporting, so that just the measures available are declining for claims-based reporting. The requirements to avoid a penalty in 2015 are the same as the incentive requirements in 2014. And additionally, there is a requirement to report at least one cross-cutting measure when you're reporting through claims and qualified registry mechanisms if you have a face-to-face encounter. And we'll go into that more in a little bit. Also, the group practice reporting option registration, GPRO registration, has changed to ending in June versus September. So that registration is occurring earlier in the year. Basic reporting requirements, again, the requirements have increased from 3 measures to 9 across 3 national quality strategy domains in order to avoid a penalty. You report 9.3 unless only 1 to 8 measures apply to the services that you provide. And you must report those measures on 50% of Part B fee-for-service cases per measure. If you report less than the required 9 or 3, then you will undergo the measure applicability validation process, which we will go into later. Also the reporting a cross-cutting measure. Or if you report a measures group, you will satisfy reporting requirements. And we'll talk a little bit more about measures group in a minute. Looking at the cross-cutting measure requirement. This is a new requirement, as I said, for claims and traditional registry reporting. You report one cross-cutting measure if you see at least one Medicare patient in a face-to-face encounter. Those are defined as general office visits, outpatient visits, and some surgical procedures. This is generally not applicable to diagnostic radiologists, but may be reportable for interventional radiologists. The list of cross-cutting measures and face-to-face encounter codes can be found on the CMS website at the link listed here. There is a list of face-to-face encounter codes, which includes over 3,000 codes. However, the 19 cross-cutting measure denominator codes include only about 200 of these face-to-face codes, basically evaluation and management, CPT, and G codes. So if you don't bill an evaluation and management code that is included in the measure denominators, or you bill less than 15 instances of those E&M codes throughout the reporting year, you are not responsible for reporting a cross-cutting measure. This is not clear in most of CMS guidance. However, there is an FAQ provided by CMS, number 12168, that gives a more clear picture of that allowance. The cross-cutting measures that seem most relevant to radiology are number 130, documentation of current meds in the medical record, or number 226, preventive care and screening, tobacco use screening and cessation intervention. Thinking about individual or group reporting, you may report as an individual using claims or qualified registry, or for the new qualified clinical data registry reporting mechanism. For group reporting, groups of 2 or more EPs can register under the GPRO option by June 30th of this reporting year. doing GPRO reporting, everyone in your group can avoid the penalty even if not all members of the group have measures that can be reported. You must use the web interface, the GPRO web interface, a qualified registry, or EHR for reporting. Large or multi-specialty groups may benefit most from the GPRO option because it may help in minimizing the reporting burden so that you could meet the 9-measure 3-domain requirement by not having to have every individual in the group meet that requirement. Small and mid-sized groups can still streamline reporting, and the GPRO reporting may be useful for them, particularly if they are registry reporting. Qualified registry reporting. So again, the larger multi-specialty groups that provide various clinical services across their practice might use the GPRO option to minimize data collection and focus on certain measures and quality improvement activities for a particular patient condition. Again, small and mid-sized groups might take advantage of that as well. Looking at the measure applicability validation process that I mentioned earlier, it's with the increased requirements of 9 measures in 3 domains, the MAV process becomes key to successful participation if you can't find 9 measures across 3 domains. So the MAV process is used to determine if additional measures could have been reported if you reported less than the 9.3. There is a separate MAV for claims or traditional registry reporting, and measures groups are not considered under the MAV. Here's a link for you for resources on the MAV and how it works, including a training course that's pretty useful. The first step of the measure applicability validation process is clinical relation or domain test. So you would want to determine what cluster that the measures you report are contained in. You can look at that cluster to see if you could have reported other measures in the cluster based on the patient's the services that you provide. If no other measures can be reported, you pass the MAB and avoid the penalty. If other measures could have been reported, then the second step is, and this is only if you're reporting through claims, the registry MAB is different. The second step is a minimum threshold test, so that if you didn't report a measure in a cluster, but you do have services provided related to that measure that you didn't report, if there were less than 15 cases of that, of those services for that measure, then you're not considered responsible for reporting the measure and you would avoid the penalty. Again, the registry MAV is different. It does not use a minimum threshold and has different clusters than are used in the claims MAV. And actually in the registry MAV in 2015, there are no clusters that include typical radiology measures. The 2015 MAV will also include consideration of the cross-cutting measure requirement. Here's just an example of the diagnostic imaging cluster number 10 that is used in the claims-based MAV. So the typical 5 measures that diagnostic radiologists report are included in this cluster. If you reported 145, 146, 195, and 225, and didn't report 147 but had cases related to the nuclear medicine measure, number 147, more than 15 instances, then you would not be successful and would be subject to a penalty. So what if you can't find 9 measures or 3 domains? Again, review the measure applicability validation process to make sure that you are reporting what you can. There is a tool that CMS provides called the Single Source Code Master, which is an Excel file that you can use to look at all the measures in the program, sort by CPT code to see if you to see what measures you can report based on those codes. Also, If you can't find 9 measures, you might want to consider using a measures group. The one measure group that's relevant to radiology is the optimizing patient exposure to ionizing radiation. So take a look at that measures group. Consider using a qualified clinical data registry. Although there is no MAV for the qualified clinical data registry reporting mechanism, using a QCDR may provide you a greater selection of measures which to report. So measures group reporting, basically a measures group is a set of 6 clinically related measures with the same patient population for the most part for every measure in the measures group. So all the denominators are the same. You must report in all 6 measures on a 20 patient sample. And only individuals can use a measures group. GPROs cannot report a measures group. As I mentioned, there's one radiology measures group, the OPIR measures group. And you must use a qualified registry. Let's talk a bit about registry reporting because there are 2 types now. There is the qualified traditional registry, such as the PQRS Wizard product or NextGen registry. And there's the Qualified Clinical Data Registry, or QCDR option, which was new last year in 2014. A qualified registry is basically a reporting registry, and you can only report on PQRS measures. The same requirements for using a qualified registry are the same as for claims-based reporting, that is 9 measures across 3 domains, and the MAV process will apply using a qualified registry if you didn't report 9 measures across 3 domains. So you can report on many as you can, and if you do that, then you may be successful without reporting the 9-3. So what exactly is a QCDR? It's an approved entity, approved by CMS, that collects clinical data for patient or disease tracking for quality improvement purposes. QCDRs are typically specialty society registries like the ACR, National Radiology Data Registry, or NERDIR. And ACR was approved as a QCDR for 2014 and 2015 PQRS participation. The measured data for QCDR measures when we're using a QCDR should be reported across multiple payers and is not limited to Medicare beneficiaries. And using a QCDR, an individual is allowed to report both non-PQRS measures and PQRS measures for successful participation. In 2014, QCDRs were limited to 20 non-PQRS measures and 30 in 2015. The requirements for using a QCDR are that you must fully meet the 9 measure 3 domain requirements. There is no measure applicability validation process for a QCDR. And in 2015, as it was in 2014, GPROs cannot use a QCDR, only individuals. However, that is likely to change in 2016. Using a QCDR, you must report 2 outcome measures or 1 outcome measure and at least 1 patient safety, resource use, patient experience of care, or efficiency appropriate use measure. You can report a combination of PQRS and non-PQRS measures. You report data across all payers, not just Medicare patients, for 50% of the cases relevant to a measure. And using a QCDR, CMS has emphasized the need for outcome measures. Potential benefits of using a QCDR: you have a greater potential to meet the full 9-3 reporting requirements. And with the increasing strictness with other reporting mechanisms, this potentially could be greatly beneficial. You can meet multiple requirements such as PQRS participation, maintenance of certification Part 4, PQI projects, using a registry for quality improvement may also help you show value to your hospitals in the contracting process. So also using a QCDR may support a better outcome under the value modifier program, where looking at your quality scores, that they are easier to monitor and improve throughout the reporting year because of frequent feedback that QCDRs are required to give their participants. There is a greater choice of measures to report, which potentially could um, allow you to report higher quality scores. You may even have measures that you can select from, more than 9 measures to select from, and choose those with the higher scores to report. The near dear registries that are included in the QCDR, so basically we have selected non-PQRS measures across the registries in near dear. That includes the Dose Index Registry, the National Mammography Database, our CT colonography registry, the General Radiology Improvement Database, and new in 2015, the Lung Cancer Screening Registry. 3 measures from the lung cancer screening measure are now included in the 2015 near dear QCDR. The web page on the ACR website will provide you more information on the measures and the QCDR. And actually, here's a list of the 24 measures for 2015 reporting. These are the non-PQRS measures. So you can see there is a selection across all of our databases. The QCDRs are also allowed to report PQRS measures for its participants. And these are the 16 measures that the ACR QCDR can report for its participants. This is just a screenshot of the PQRS QCDR webpage on our website. You can see basic steps for using the QCDR, some documents that we provide to give you more information on reporting through the QCDR, and a link to our website. Just a snapshot of the QCDR measure report from 2015 for the Dose Index Registry QCDR measures, and for the National Mammography Database measures. We are in the process of updating the measure reports for QCDR measures. So now let's go into linking PQRS and the value modifier. But before we do that, let's just take a breather, let some steam out, and forward. So the value-based payment modifier was authorized under the Affordable Care Act. It's based on an assessment of quality and cost of care. It builds on PQRS measure performance rate, including measures that are reported through a qualified clinical data registry. It does allow for differential payments or tiering of payments to groups, TINs, of physicians under Medicare Part B. CMS is phasing in the value modifier based on group size. And in a calendar year 27, the payment adjustments based on 2015 reporting also apply to groups under Medicare Shared Saving Program, Pioneer ACOs, and other demonstrations and models that CMS is conducting. In 2018, the payment adjustments will also apply to non-physician eligible professionals. There is automatic value modifier penalty for not participating in PQRS, and there is a payment adjustment of positive, neutral, or negative under quality tiering for PQRS reporters, or those that were successful with PQRS. The value modifier is analyzed at a group level, where individuals in a group performance scores are aggregated up to the group level. So if you are a registered G-Pro, then you're successful in the PQRS program, your scores are the aggregated scores are used for value modifier. If you're not a registered G-Pro, then if 50% of the individuals in your group successfully reported PQRS, those individuals' scores are aggregated for the value modifier. And looking at thinking about the cost measures in the value modifier program, it's likely that only one of the cost measures currently used will apply to radiology groups, basically because of the attribution method used for the cost measures. Going into a little more detail on how the value modifier assessment is being implemented. As I said, it's being phased in by group size. And looking at, let's just look at this year, the 2015 year, reporting year, performance year, and the 2017 value modifier assessment year. So for groups of 10 or more, the downward adjustment is a maximum negative 4%. That is if that's under the quality tiering, or for PQRS non-reporters, there may be a no adjustment under quality tiering, or an upward adjustment at a maximum of a 4 times factor. The program is budget neutral, so the level of the percentage of the upward adjustment will not be determined until after the program is complete, the program year analysis is complete. Again, in 2015 performance year, for the 2017 value modifier adjustment year, groups of 2 to 9 and solo practitioners may receive a downward adjustment under the value modifier, but only if they are PQRS non-reporters. There is no downward adjustment for groups of 2 to 9 and solo practitioners in 2017 under quality tiering, and the upward adjustment potential for groups of 2 to 9 and solos is up to a 2 times factor. Looking at that again in a different visual format, groups with 2 to 9 EPs and solo practitioners that did not participate in 2015 PQRS will receive a negative 2% value modifier penalty, which is in addition to the negative 2% PQRS penalty. If those size groups did participate in PQRS successfully, there is no negative adjustment under the value modifier and a potential upward adjustment based on quality tiering. For groups with 10 or more for the value modifier in 2015, based on 2015 data, those that did not participate in PQRS in 2015 will receive a negative 4% value modifier penalty in addition to the negative 2% PQRS penalty, for a total of 6%. Those that did participate in 2015 PQRS may receive up to a negative 4% value modifier penalty, or no adjustment, or an upward adjustment under quality tiering. So let's look at quality performance under the value modifier. Your PQRS measure scores for the program are standardized and compared against the national mean from the previous year. So for 2015 PQRS reporting, your scores are compared to the 2014 national mean. QCDR measures will also be used in the value modifier, but first year measures, or those measures where 2015, for example, is the first year of reporting, those will not be used for value modifier calculations. So the 6 national quality strategy domains are used in the value modifier, where each domain, within each domain, the measures associated with that domain are equally weighted and averaged for a domain score. The domain scores are equally weighted and averaged into a quality composite score, where your scores are bucketed into either high, average, or low quality based on your percentile and deviation from the mean. So a -1 standard deviation would put you in a low quality bucket. A +1 standard deviation would put you in a high quality bucket. The cost measures, there's currently 5 total per capita cost measures, 1 overall total per capita cost, and 4 condition-specific per capita cost measures, conditions such as COPD, heart failure, diabetes, and asthma. In 2015, CMS has added additional cost measure, the Medicare spending per beneficiary measure, which is based on an inpatient admission episode, looking at 3 days previous to the admission and 30 days post, and looking at the cost for that episode. The Medicare spending per beneficiary measure may be attributable to radiology if the cost of services that a radiology group provides during that inpatient admission are higher than for costs associated with other groups that provided services during that inpatient admission. The same scoring methodology is used for the cost composite as is used for the quality composite. That is rolling the measure score up into the domain score, and the domain score rolling up to the composite score. If no measures are attributable to the group in the cost composite, then the score is considered average, and looking at it visually. So each of the PQRS measure domain scores are calculated, and the domain scores are rolled up to the composite. Same with the cost measures into the cost composite to give you the value modifier amount. So looking at those steps again, PQRS reported quality information and CMS calculated outcomes and cost measures are analyzed. Each group practice receives two composite scores, quality and cost. CMS classifies each score into high, average, or low based on standard deviation and comparison to the national mean. That identifies statistically significant outliers. The groups are assigned to respective quality and cost tiers to determine a positive, neutral, or negative payment adjustment under quality tiering analysis. So looking at the 2017 adjustments based on 2015 reporting, groups with 10 or more EPs, the automatic downward adjustment for not successfully reporting PQRS is a negative 4%. Under quality tiering, the potential upward adjustment maximum is a 4.0 X factor. As I said, that's a budget neutral program, and the upward adjustment is only determined after all the negative adjustments are determined. So the payment at risk is a negative 4%. That's the maximum. You could incur a negative 2% penalty under quality tiering if you had high cost but average quality. For groups of 2 to 9 and solo practitioners under the quality tiering in 2017 based on 2015, the automatic downward adjustment is a negative 2% for not successfully reporting. Under quality tiering, the potential upward adjustment is set at a 2.0 X factor. And groups with 2 to 9 and solo practitioners can only earn an upward or neutral payment under quality tiering. Let's talk a bit about the physician feedback program, and basically that includes the quality and resource use reports. These are important as you begin to learn more about how the value modifier may affect your reimbursement. And the QRURs are annual reports that provide your group with comparative information on quality and cost to give you an idea how you will fare under the value modifier adjustments. There are supplementary reports or drill down tables provided to you with the annual reports that give specific information that may help you determine how you can improve your scores both in quality and cost. Currently, there is a 2014 mid-year QRU available. This is based on data from mid-2013 to mid-2014 and does not yet include PQRS measure information reported using claims or traditional registry. It does include data on the Medicare spending per beneficiary measure and may be the most useful piece of information in the mid-year report. In the fall of this year, the 2014 annual QRURs will be available for all groups and solo practitioners. This will include PQRS measure data reported in 2014 under any mechanism reported, and will show you, your group, how you will do under the 2016 value modifier payment adjustment for groups of 10 or more. You can also look at national benchmark rates for PQRS measures at the link shown here. These benchmark rates will give you an relative idea of what your PQRS performance scores are comparatively to the national mean. Here's just a snapshot of what the Quality Resource Use Report looks like, the full annual report from 2013 data. And looking at the cost measures and the Medicare spending per beneficiary measure. So this looks at cases in which you had patients where their cost for their inpatient admission was associated with your group's services was greater for any other group that provided services to that patient for that inpatient admission. The per capita or per episode cost is what your average costs were for those cases, and is compared to the benchmark for all groups who had data under the Medicare spending per beneficiary measure. So that's the average cost for that measure. And then your costs are compared within a -1 or a +1 standard deviation. So if for this example, the group was within the standard deviation, so their costs would be considered average. One other aspect of value-based purchasing program that we need to pay attention to is the public reporting of quality and cost data. This is being developed under the Physician Compare website, which is similar to the Hospital Compare website, currently providing demographic and practice info as well as quality program participation, that is PQRS or Meaningful Use Program. However, in late 2016, Physician Compare will include information on all 2015 PQRS GPRO measures reported, all 2015 measures reported by ACOs, all consumer assessment for healthcare provider services for PQRS, and CAPS for ACOs that was reported in 2015, and all 2015 PQRS measures reported through claims, registry, EHR, and web interface. The registry is both traditional and qualified clinical data registry measures. QCDR measures are reported at the individual level versus group level on the Physician Compare website, and both PQRS and non-PQRS measures are reported. And as I mentioned earlier, under the Value Modifier program, no first-year measures will be reported on the Physician Compare website. CMS has stated that measures will be posted if they are technically feasible, that is, that they are reliable and have a minimum 20 patient sample size for measures that have been reported. Here is a few links for PQRS and value modifier resources. So I know that was a lot of information, and hopefully we have a good amount of time for questions. So you can either raise your hand and we'll unmute you so you can ask over the phone line, or just enter questions in the chat box. Thanks.